Good morning, everybody. So today we'll cover the peripheral nervous system. The initial objective was to look at the anatomy and the physiology of the same, but also a bit of clinical relevance. It's part of the main reason that we are here. So as I was saying, we'll look at a bit of anatomy and physiology and also tie it up to a bit of clinical relevance. And it's part of the reason why we are here. So these are my objectives over the next couple of minutes. So the peripheral nervous system is one of the two main parts of the nervous system, the other part being the central nervous system. And this particularly consists of nerves and ganglia that operate outside of the brain and the spinal cord, and whose main function is to connect the central nervous system to the peripheral limbs and the organs. So they basically serve as a relay point. Now broadly, the nervous system, the peripheral nervous system, can be divided into sensory and motor. Motor can then be further divided into somatic and autonomic, which can then be further divided autonomic into sympathetic and parasympathetic. And we'll go into this in further detail. So if we're to look at the basic structure of the peripheral nervous system, first of all you have the sensory receptors, which pick up stimuli both internally and externally of the body, so from the skin to the internal organs. And this then transmits these impulses, electrical impulses, via afferent nerves, which then go to the dorsal root of the spinal cord and up to the central nervous system via tracts that we'll look at. And the efferent component of it comes out of the ventral root of the spinal cord to then supply the various effector muscles, which we'll look at in detail as we go. But generally, from the receptors, you have nerves which consist of bundles of axons, basically peripheral axons form nerves. And this then sort of meet up at the ganglions, and the ganglions is just it's a collection of cell bodies, neuronal cell bodies of the nerves before transmission to the spinal cord. Basic physiology. So if you look at the structure of the nerves, there are three main components of the nerves. First, you have the endothelium, which is a delicate sheet of connective tissue around the axons. These are the axons. Outside the endothelium, you have the perineum, which is the connective tissue which surrounds the nerve vesicle. And the nerve vesicle is basically a bunch of axons bound into bundles. And then surrounding all of this is the epineurium, which is a tough fibrous sheet that is protective of the nerve vesicles. Now, the axons are surrounded by Schwann cells, and Schwann cells are important in neuroconduction to look at the physiology. The importance of these layers is sometimes you can have disruption of blood supply, for example, to the epineurium, leading to disintegration of the same. And the effect of that is decreased transmission of electrical impulses, which would then give you symptoms of peripheral neuropathy. Now, the different types of nerve fibers are three of them in broad classes. The largest being the type A fibers, they're the thickest and also conduct the fastest. They are surrounded by myelin, and the speed of conduction goes from 4 to 120 meters per second. We'll look at the various subgroups in the next slide. Then you have our type B fibers, which are medium in size, they're also myelinated, but if you look at the speed of conduction, it's slightly slower, 3 to 15 meters per second. And the type C fibers are our smallest fibers, they're non-myelinated, and hence at the smallest rate of transmission, or the lowest rate of transmission, going up to 4 meters per second. To further discuss this, I hope it's clear enough. So the A fibers, which have the fastest transmission, they mostly have a function, they mostly respond to functions which need quick response. For example, if you look at the motor function, tactile function, and maintenance of muscle tone, these really need fast transmission from the receptors to the effector muscles, hence the need for a quick rate of transmission. Now, our B fibers, they're mostly found in the preganglion sympathetic nerves, and these have an autonomic function of the autonomic nervous system. The C fibers serve two functions. One, they're found in the postganglionic sympathetic nerves, but they also play a role in regulation of warm temperature. So if you look at the difference between the A delta fibers and the C delta fibers, you notice that the A delta fibers will mostly be involved in cold temperature transmission, but for the C fibers, you have warm temperature in touch. And if you take a practical example, you realize that you respond much quicker to cold sensations as opposed to warm sensations.
For a request and nerve conduction, usually what we are able to do is F fibers and G fibers. You can do autonomic studies. C fibers we are not able to do. Therefore, when we report nerve conduction is normal, actually it depicts fibers F fibers. We don't do autonomic studies in this hospital. But the nerve conduction is it's normal, it's F fibers. Therefore, we can have pathology B fibers, C fibers. Patient can go, you can get the nerve conduction and it's really normal. Then you wonder why the patient still that pain. Therefore, that is why eventually we do biopsy of the day to study C fibers.
Projector quality is quite poor. But for there to be an impulse of electricity transmitted, there has to be receptors which would then pick up these stimuli and transport them to the various destinations needed. Now, sensory elements, the receptors, they pick up 4 different types of stimuli, 4 different attributes of stimuli. This includes the modality of the stimuli, whether we have warm temperature, whether we have pain or proprioception. They also pick up the location of the stimulus, whether it's peripherally, whether it's internal organs, and the intensity of the stimulus, and also the duration of the stimulus. Those are the 4 elementary attributes of stimuli that you receive. Now, if you take an example of the human hand, we have 4 types of mechanoreceptors. What about projection? But you have the Meissner's corpuscles, the Merkel cells, Pacinian corpuscles, and the Ruffini endings. Now, these act they do not act singly, but they act together to produce a general feel of sensation. Now, for selective activation of the Merkel cells and the Ruffini endings, respond mostly to sensation of steady pressure. Okay? And that of the Meissner's and the Pacinian corpuscles will respond mostly to tingling and vibratory sort of sense. Now, the intensity of this will determine how much action potentials are generated, which will then determine how much of a response we perceive from the same. And as you can see, if you look at the receptive field, the Meissner's corpuscles are mostly located right in the middle of the finger. So they're quite specific, quite sensitive. And as you go towards the Ruffini endings, it spreads out more peripherally. So in essence, you have your whole finger being covered. But for them to be able to interpret this appropriately, they have to act together in conjunction. So nociceptors, pain and temperature receptors, they arise from unmyelinated dendrites of the sensory neurons, which are located either in skin or glandular tissue or in deep internal organs. There are 4 particular types of nociceptors, or mechanical receptors, which respond to strong pressure. We have the thermal nociceptors, which are usually activated by temperatures above 42 degrees or by severe cold, normally less than 35 degrees. We also have the chemically sensitive nociceptors, which respond to irritants such as bradykinin, histamine, high acid levels. And some receptors do have a combination of all the 3 combined, so they're referred to as being polymodal. Now, once you have these sensations being perceived and transported to the dorsal spinal cord, they need to be transported up to the brain for transmission. And there are various tracts that respond to these, and we'll go over 3 big groups. So the first one we'll go over is the posterior column medial lemniscus pathway. which normally responds to touch, vibration, and proprioception. So, I'll send you the slides. There's a better slide coming up. But the fibers are sent without interruption on the ipsilateral side of origin to the second order neurons in the nucleus gracilis and cuneatus. At this point is where they decussate to become the internal microfibers, which will then go through the brainstem in the medial lemniscus pathway. And the medial lemniscus pathway will then terminate in the ventral posterior nucleus of the thalamus. And this is the third order neurons. And from this, you go to the somatosensory cortex, where you then have your perception. It's a better image. We'll go through it first. Yeah. So this is basically what we're talking about. Ascending ipsilaterally at the level of the medulla, decussating to the medial lemniscus pathway, to the third order neuron, the thalamus, before going to the somatosensory area of the cerebral cortex. Now, we also have the spinal thalamic tract, and the spinal thalamic tract normally transmits pain and temperature. Yeah. So they're normally located in the lateral and ventral to the ventral wall of the spinal cord, the area shaded blue, and they carry pain and thermal sensation. But also on top of this, they have non-discriminative touch and pressure. But these fibers are not particularly distinct as they travel up the spinal cord, but they are intermingled. But however, they are arranged in a somatotopical way, meaning that those fibers in the lower limb tend to lie the most superficially, and those in the upper limb lying deeply. This is a demonstration of the spinal thalamic tract. They decussate at the level of the spinal cord, sometimes 2 to 3 levels higher, before going up to the second order neuron in the midbrain and the medulla, prior to going to the contralateral part compared to the origin.
Clinically, how do you explain sensory determination of the sequence?
Ipsilateral loss of proprioception and vibration, and contralateral loss of pain and temperature.
And finally, we have the dorsal column system, which mediates for discriminative touch and position sense, as opposed to the spinal thalamic tract, which is non-discriminative. Now, what you notice about this is that the fibers from the lower limb tend to be more deeper compared to those of the upper limb. This is inverse to what you expect in the spinal thalamic tract. And also for the dorsal column system, they tend to travel, they ascend laterally to the medulla before synapsing with the cuneate and gracilis to cross the midline, to then end in the sensory cortex and thalamus. This is a slide that breaks down most of what we discussed into further detail. Is this something we can look at a later point? It tells you where the first order neuron is, the second order neuron is, the destination of the fibers, and finally where they decussate. And based on that, you can be able to tie it up clinically to what you see. So how do we correlate this clinically? So one, if you're assessing for the lateral spinal thalamic tract, it's best assessed using either the pinprick or the temperature test. If you're assessing for the anterior spinal thalamic, the fasciculus brachialis and cuneatus, then our examination will include a joint sense proprioception, vibration, tactile localization, a Romberg's test, and the like. Now, for our dorsal spinocerebellar and our ventral spinocerebellar tracts, this is what we test through the cerebellar exams. The finger pass pointing, heel knee, shin test. And the spinal olivary and spinal tectal is what we test when we check for visual and proprioception tests. Now, normally, this comes into clinical significance in conditions such as Brown-Sequard syndrome. And could someone remind us what a Brown-Sequard syndrome is? No, like what does it manifest as? how would a Brown Sequard syndrome manifest? Let me put it like that.
She just said it.
It's bilateral loss
Okay.
of proprioception and vibration and contralateral loss of pain and temperature.
Okay.
And syringomine.
It's in the center.
It'll affect
the
both.
spinals a lot.
It has that, isn't it that glove and stocking manifestation if it's in the cervical region, where initially it affects the anterior commissures and then spreads around to cause a glove and stocking sensation.
Okay. Okay, so
It expands from the
syringomine
center.
is usually at the center.
At the same time.
Yeah.
And the fibers which are around the central are autonomic. And then you have decussation of the fibers of pain and touch are crossing over. Therefore, at that point, you'll get its lateral findings. And then the opposite will be contralateral after that, will be below that.
So the next thing we look at briefly are spinal nerves. And spinal nerves they come out in 31 pairs, but these contain thousands of nerves. They connect to the spinal cord, and they're of course named for the point at which they exit the spinal cord. And those are the numbers we expect. Now, when they come out, they form nerve plexuses, and these are basically a network of nerves. And there are four major plexuses: the cervical, brachial, lumbar, and sacral. The cervical being mostly involved in the neck muscles, the brachial being involved in the upper limb muscles, and the lumbar and the sacral being involved in the lower limb muscles. So these you can be able to localize where the lesion is based on what you see. We'll come along that. Now, the cervical plexus is found right under the sternocleidomastoid muscle and is formed by the ventral rami of the first four cervical nerves. And most of them are cutaneous nerves, but some will innervate the anterior muscles of the neck. The brachial plexus is found in the neck and in the axilla. These arise from C5 to C8, and they give rise to the main nerves of the upper limbs. So usually if you have an axillary injury, you do expect some deficiencies, which we'll talk about later. And the lumbar plexus from L1 to L4.
In which tumor spreads to the cervical plexus
From that?
from the nerve?
So one of the best ways to localize sensory lesions arising from probable spinal cord involvement is use of our dermatomes. I'll put this diagram up just so that we can be able to sort of internalize and cram the various dermatomes when we're doing a sensory exam. So next we'll talk about motor controls and reflexes. So the reflex arc consists of about 5 elements. One, you have a receptor, which responds to a stimulus by producing a generator or receptor potential. What a generator potential is, it means you have mild electric responses that accumulate to reach a certain threshold, usually about 10 millivolts. And when they reach a certain threshold, then you have an action potential, which is an all or none response. So you have, depending on the intensity of the stimulus, you have a slowly building up potential till you reach an action potential level. Then you have an all or none response of the nerve, which is then transmitted up the sensory neuron. So once it's transmitted up the sensory neuron at the level of the spinal cord, you have an interneuron which acts as a modulator in the integrating center. We'll look at that in detail in the next slide. The effector, the efferent neuron usually is a motor neuron, which then will conduct impulses from the integrating center to the effector, which is a muscle or a gland, which then responds to the reflex that we have elicited. So this is what I was talking about. One, you have a generator potential, which will lead to an action potential in the afferent neuron. The synapse will have an excitatory postsynaptic potential or an inhibitory postsynaptic potential. These basically either act to further excite the reflex or to inhibit the reflex. And based on this, you then have an action potential on the efferent nerve, which is either strong or weak, depending on the level of inhibition, which then travel to the end plate to create the intended effect.
Now, clinically, what is F wave? When we report in the nerve conduction F wave,
Incomplete.
F wave is actually a reflex. But F wave do not have the same distance. The reason is because when you stimulate here at the generator potential, there is interneuron. And that interneurons can be transmitted at different rates. That is why F waves have a different length. And then you get the effect that efferent is stimulated. And that's what we call F wave. H reflex is almost the same. That is the only part we just like a reflex. And when we say F wave is this, he's going to talk about it. We are doing nerve conduction studies.
Move forward because we have a long way to go. I will briefly talk about the autonomic nervous system. Now, the autonomic nervous system, as opposed to the somatic nervous system, is a two-neuron pathway, in the sense that you have a preganglionic neuron, which is myelinated, the B fibers we talked about. You have an autonomic ganglion in between, and after that you have a postganglionic neuron, which are the C fibers and the unmyelinated. And then the effect will either cause release of acetylcholine or norepinephrine, which you see the effects of the same. So the preganglionic neuron has its cell body in the brain, the spinal cord, and it's myelinated to B fiber. The postganglionic neuron lies outside the CNS in an autonomic ganglion, in the unmyelinated C fiber. Now, the sympathetic nervous system originates in the spinal cord, and when the spinal cord does it originate? So it's thoracolumbar, and it gives us the fight or flight response. Of note is that it utilizes norepinephrine as a neurotransmitter for its effects. The parasympathetic nervous system arises from lymphosacrum, and it's a rest and digest sort of response, and it utilizes acetylcholine as its neurotransmitter. Broadly, these are the expected effects of the parasympathetic and the sympathetic nervous system. So next we'll talk about nerve conduction study, which is Dr. Mativo's domain. But nerve conduction study is a measurement of speed of conduction of an electrical impulse through a nerve. So it tells us whether there's nerve damage or whether there's destruction. What we normally measure is the conduction velocity. And what you do by this is you measure the time it takes for an impulse to travel between two electrodes, and then you sort of divide it into two.
When you look at this point, that point, before it, positive wave is downwards in neurology, in neurophysiology, negative is upwards. Actually, the onset is when the positive point starts. That is when the fastest fibers start. And then this amplitude is how many fibers are being stimulated. Then it relaxes. Therefore, that's all what. Therefore, we measure the fastest fiber, and that is what we call distal latency. And the amplitude. Amplitude looks at the number of fibers which have been stimulated, and the duration. Duration, that's called temporal dispersion. How long has it taken for a number of fibers to be stimulated? Therefore, the duration is from this point, that point where the fastest fiber started, to the end of there. As we call it temporal dispersion. When we say it's increased temporal dispersion, it took long to stimulate all the fibers.
So the procedure is done as he has described. But what it does, it tests the motor, the sensory, or both motor and sensory mixed together. So normally the way you get an impulse is you give an electrical current until you get a maximum response. So you look at your amplitude and amount of nerves being activated. And once you think you've reached the threshold where all nerves are being activated, you go 10% above that. This is what is described as supramaximal stimulation. And the reason we do that is to make sure that all nerve fibers are recruited. Now there's a concept.
What he's talking about is when you reach this amplitude, that's the current, that's the maximum current. Then if you increase, that will never decrease. Okay. Therefore, that's the maximum you reach. You go to the maximum current, whereby the amplitude is not going to rise. Therefore, you can increase 10% of that.
And what you get after this activation of all the nerve fibers is the sensory nerve action potential, which is then the response to stimulation. It's usually referred to as SNAP in our reports that we look at. Now, this amplitude, which is the waves he was talking about, it gives us an idea of how many axons have been excited. We've talked about the conduction velocity. Now, in motor studies, what happens is you stimulate a motor nerve and record activity over the muscles that it supplies. And then the resultant response is what is referred to as the compound muscle action potential, the CMA, that you normally come across. Now, the CMA.
What we are describing, you talk about the distal latency, the duration, the amplitude, and that means the velocity. Then you calculate the velocity. The reason why we don't have the chart whereby it's going to be. Why we do 2 points? Because here, and then you repeat another point. The reason is because when you stimulate, there is a neuromuscular compartment, whereby it might slow when the nerve is stimulating the muscle. Here we need vesicles like synaptic cleft. That might give you slowness. Therefore, we need two points to measure which have no effect on the neuromuscular junction. That is where we have 2 points. So that we don't have effect of that neuromuscular junction, because neuromuscular junction is slow. Therefore, it can give you slow velocities.
Now we talked about F waves, but F waves are produced when you have an action potential which travels to the motor fiber. Like that.
Yeah, it just stimulates not interneuron. That slows it, and that is where we have different latencies to the at the interneuron level. And therefore, just a reflex. And as we have noted here, the fastest, earliest changes you see in the imagination, like in human body, is F latency is prolonged. And I think we had a patient, we stimulate patients day 1, day 2. Everything else is normal except F latencies in GPS. I think there's also another patient. We just reported F latency, but I usually add full of GPS because people might not think this is GPS. If you delay in GPS, usually in the books they say 2 weeks. You see all the features of GPS. But patients, when they come day 1, day 2, they need to be treated. So the fastest goal is F latency. F latency cannot localize in the lesion. Okay? Because it's a long distance. It's a very long distance. Everyone tells you there is an abnormality on the path of that nerve. But it can't tell you which abnormality.
The take-home message for us nerve conduction studies is one, it's sensitive in detecting peripheral nervous system disease and sometimes can allow for precise anatomical localization. We have to be cautious in patients who have defibrillators or pacemakers in place. And also at the same time, when you are sending for nerve conduction tests, it's good to give a good clinical history because it guides specifically which nerves to look for. Normally, you could have, at very early stages of disease, you could have a normal nerve conduction study. So sometimes it can be necessary to repeat this. And if you do not understand the report clearly, sometimes it will be quite complex. Feel free to call Dr. Martin. So next we'll go a bit into clinical picture, which is more fun. So motor neuropathies, the way they would normally present is with progressive weakness or clumsiness. Patients report that have difficulty walking, they find themselves stumbling over. Sometimes they can present with respiratory difficulties, which can be so subtle that can only be picked up on lung function tests by decretion, for example, in vital capacity. Or they can present with wasting, sometimes with foot or wrist drops. Or during a normal examination, you find that reduced or absent deep tendon reflexes.
But we can divide this as proximal presentation and distal presentation. Usually ask for distal presentation is ask the patient, are you able to wear slippers? Okay, simple things using the feet. Proximal, are you able to climb upstairs? Are you able to stand up from a seated position? And those are what he has described here. But the issue is to tend to divide them with proximal presentation or distal presentation.
And autonomic polyneuropathy would present usually with features of postural hypertension, sometimes urinary retention, sometimes erectile dysfunction, changes in bowel habits, diminished or increased sweating, or sometimes with arrhythmias. And this is normally seen in patients with chronic diseases which then lead to neuropathies such as diabetes, amyloidosis, and GBS.
In GBS, you have to do an ECG. The reason is you need to rule out cardiac arrhythmias. They can get an autonomic dysfunction. Diabetes is a classical picture of any neuropathy in human beings. They present with any form of neuropathy. Peripheral, autonomic, plexopathy, anything. But these are questions when a patient comes to you to ask about autonomic system, urine control, vision, gastroparesis, all those questions you should ask when looking for autonomic neuropathy. And commonly you will get patients with diabetes and they tell you I'm constipated. And then these patients are just given dark blood or something like that. But it's actually autonomic neuropathy. And rarely I've ever seen most clinicians write diabetic autonomic neuropathy. You never try to see that. Therefore, remember autonomic neuropathy and diabetes is very common. Especially gastroparesis, bloating, all these things you have had patients tell you, I feel bloated, constipation, diarrhea, sometimes more constipation.
And for sensory polyneuropathy, can look at the presentation. Normally, you see this in our diabetic patients when they come in with paresthesias, numbness, binding sensation that are severe, as at night, not relieved by position. Sometimes they come with loss of vibration sense or position sense, which they might not sense. The way you tell is coming with unexplained wounds because they cannot feel where their foot is. Some can come in with very subtle things, for example, say I can't thread a needle, or with an ataxia, which is usually due to loss of sense of posture, or a glove and stocking sort of presentation. we talked about.
By the time the glove is stopping neuropathy, which is the knee, the hand starts. But the hands are already, patient is already telling you the hands, and it's a diabetic patient, that's neuropathy is about the neuropathy. If it's an ascending type. But in stop and glove presentations, you need to look for other metabolic causes. Rarely you're getting, you get it in metabolic causes, or infective causes, or toxic causes. Inflammation tends to give you a bit of asymmetry, but GPS creates symmetry.
So, something important for us with the mechanisms of peripheral neuropathy, and there are 6 mechanisms which have been elucidated. One, you have demyelination, for example, in GBS. You also have axonal degeneration and toxic neuropathy, Wallerian degeneration, compression, for example, carpal tunnel, infarction of the nerve, diabetes, infiltration, such as leprosy and granuloma. So, I didn't go into the details of pathophysiology, because that would be more for the clinical oriented, Dr. Soto said.
What's Wallerian degeneration?
Wallerian degeneration is, you cut the nerve, let's say at this level, therefore it generates backward. It goes down. At this point, we start getting degeneration.
So, distal degeneration.
Yeah.
And the types involved can be quite interesting, because you could either have an acute or chronic presentation, you could either have one nerve being affected or two or more nerves being affected, usually in a symmetrical disease, starting peripherally, such as in GBS. Or you could have a mononeuritis multiplex sort of syndrome, which affects several or multiple nerves, or a radiculopathy, which would then affect your nerve roots of the spinal cord level. Well, the peripheral neuropathy would then affect the different modalities which they represent, like senses, motor, autonomic pathways. Now, if we were to look at broadly investigations, and not into detail, these are the basic labs that you should try and get for a patient with a neuropathic sort of presentation. From your labs, a urine analysis, a CBC, vitamin B12, folate, ESR, HbA1c, kidney function, liver function, or TSH. And if
connective tissue screen. Okay, why don't we not biopsy we can do? Just biopsy the pseudo nerve or the dental nerve. But the problem with doing nerve biopsy, you don't have a neuropathologist to do it. You study the nerve in this, and then you don't have an electron microscopy for that. Because you need to biopsy and take it to electron microscopy within less than 30 minutes. So that you can do immunoelectron cytochemistry and study the proteins of the nerve nicely. If you do nerve biopsy here, it's just a waste of time. That's why you find you don't do. Myself, I can't do because I'm not doing add any value. But the commonest nerve biopsy is pseudo and epidendal is just because you can biopsy the muscle and the nerve. But if you just want the nerve, you go usually the pseudo. And pseudo will give you the nerveness over the skull and a bit of the side of the skull. And usually within 2 years, there's recovery of the sensitivity. The lab request here we need extensive connective tissues screening, or doing your plastic screening, because we can have a plastic screening presenting from all those things are not in the products. I think we will add.
So, to tie it up together, we'll discuss a couple of cases. I think any volunteers to go to the first case. Calvin. Nice.
peripheral went to the inner circumference of the brain. Gap, the right hand of tissue, that's one shock. Followed by weakness of both lower limbs the next day morning. It was bedridden after demonstrated weakness, his body bladder was injured. He is able to feel sensation of close over the lower limbs. He felt 10 minutes of use taken to a local hospital and given treatment where he got his weakness. Symptoms of failure and deformity, fever, onset of weakness, no history of apparent exertion, no history of job life, no history of seizure episodes, no symptom of fluids in the past, no history of symptoms of like DBA.
What describe the clinical observation?
Keep going.
Clinical examination, the patient was conscious for having no pala, no icterus, no clavicle, edema. Blood pressure was 100/70, pulse rate was at 80, respiratory rate was at 80. Motor system showed hypothermia of one of the limbs, red, 3 or 5, the upper limbs, 4 or 5, and TJ was 2 or so reflexia, deep and reflexes, absent, unbody reflex, sensory, what do you suspect that?
So what do you suspect?
So what's the clinical?
Clinical
Describe that first.
So he has peripheral, what looks like a peripheral neuropathy, ascending, purely motor. Yeah, it's acute in onset. It's flaccid paralysis. Hyperreflexia, which confirmed. Central cause. Sensory zinc, likely armor.
So how would you go about investigating this patient?
Like we said, you don't have connections.
It's very specific.
In the area. Other things you can do that will remove that because you have other devices.
So yeah, Katrina talks about the number of punctures. And what are we looking for in the number of punctures?
Leocytosis
With
no protein.
So you have high levels of proteins, low levels of white cell.
what do you call that?
We find the cells are elevated. If you find they are elevated.
It can be.
I think Kuka can tell us
It
about
can
it.
be elevated. But your sister thinking about it really It can be transit.
So when early on, yeah?
Yeah.
We had a patient who presented just like that. Finding
Especially if you rule out infective causes. If the cell, DBS is inflammatory only, but infective cause will have self-control before you do infective cause and can be any other infection which can present with DBS switch.
Perfect. We can do the next case. Any volunteers?
Number 60, female presents with complete tingling affecting the thumb, index, and middle fingers of the right hand. The syndrome began spontaneously about 4 months previously and was not associated with any injury or change in her activity. She first noticed this symptom at night when it disrupted her sleep sporadically. She first noted this symptom at night when it disrupted her sleep sporadically at the outset, but in recent weeks on almost a nightly basis. She is employed as a legal secretary. Her rest has talked about. The physical examination of the right hand does not reveal abnormality on inspection. In particular, the bulk of the intrinsic musculature of the hand, including the thinner eminence, is normal. There is no tenderness to perfusion on the hand. The neurologic examination shows the strength of the abductor pollicis muscle is normal and is rated as being firm. When you suspect any further examination of the hand, is retrieved. So, the clues that you can pick up in the history go back. So, the symptoms are affecting the thumb, the index, and the middle finger, which suggests media neurology. And then the fact that she's employed as a secretary means she may have repetitive hand movements at the wrist, which would predispose her to carpal tunnel syndrome. On examination, so the intrinsic muscles bulk is normal. I think that's, I'm not so sure, but I think it's the ulnar that does that, so that shows it's likely not related to and then the normal strength in the abductor pollicis brevis. So that's medium. The low muscle. Yes, medium. So it's medium now. So
What else supplies supplied by medium nerves in the hands? Which is we should ask the question.
Lateral to the left one.
What else? It's autonomic system, which you should ask the question. Yeah. Autonomic symptom, you should ask the patient with carpal tunnel syndrome. You will ask if they sweat their hands. Okay? They'll tell you, my hands have been dry, they don't sweat. Because it's also supplied by the medicine.
Alright.
So I suspect carpal tunnel syndrome. Further examination required, you can do the Tinel sign and
I'm showing it. Antonina is already on it.
Tinel is tap on the area of the medial nerve to elicit either pain or paresthesias and allow the distribution of the medial nerve. Listen. So you elicit the symptoms because of course you're compressing the
And reverse hands. Yeah, that's a reverse.
Strength.
Yeah, this is a reverse.
And investigation.
Nerve conduction.
There's a catch. There's a catch. There's a reason why that is that. So what else can cause carpal tunnel syndrome?
Hypothyroidism, Cushing,
Doses.
Pregnancy.
Pregnancy.
trauma,
That was a catch.
megaly,
Yeah? Acromegaly. Yeah. So is this now the final case we'll do. Cooks, take us to this portrait.
So he's a 22-year-old man, electrician, with no relevant personal or family history. He complains of limitation of voluntary extension of the third, fourth, and fifth fingers of the right hand, without pain, paresthesia, decreased sensitivity, or other accompanying symptoms. No history of trauma. The neurological examination was normal, except paresis of the paresis of extension of the third, with mild muscle weakness, grade 4 or 5, no sensory changes or symmetrical reflexes.
So in the exam, this is what you find. You describe to us what you see.
So the left lower limb, the left upper limb, sorry. And if there is obvious atrophy of the muscles, and then there is this one, which is go back to this again. So it's on the right hand. So it has symptoms of lower motor neuron weakness, like he has a limitation in terms of weakness. Let's go back to the image again. So it's the right compared to the left. There is definite evidence of wrist drop at that side. So if you compare the clinical presentation, the fact that he's an electrician and predisposition to any injuries, the elbow joint. So I think it's likely a nerve entrapment, actually radial nerve. If you get
Unless it's the humerus, it's the
humerus
fracture. But over here, it will be the ulnar.
Where?
The ulnar, the elbow.
This guy can't even extend his elbow, which means the lesion is higher up.
Yes, so it's the humerus.
So probably the brachial plexus. As an electrician, I guess he does that.
Wouldn't he have the nerves?
The nerves.
The other nerves. It's mostly radial. Symptoms are radial.
So they're radial and they're mostly from the presentation is mainly motor.
Look at the left hand also. There is wasting of the Russia's muscles. There is wasting, that's wasting. Okay, you examine this patient and you find the upper motor sign in that right hand.
So if you find the
Upper motor signs, that reflects here.
on top of the presentation.
Just on top of the waist.
So
What do you think?
anytime you get a combination of upper and lower motor neuron, think of motor neuron disease, things like ALS.
Yes, there's a Why do you have upper and motor signs in these patients in ALS?
So there's involvement of both the upper motor neuron, this degeneration of both the upper and the lower motor neuron. So both in the brain, the spinal cord, as well as the exit of the lower motor neurons.
What happens is these motor neurons just degenerate. They degenerate at different levels. And if, let's say, degeneration was higher than the upper limb, you have upper motor signs. But at the same time, you have degeneration involving that region, motor neuron degeneration involving the hand itself. Therefore, you have wasting. But because there is also degeneration above that, you get motor signs. Therefore, you find they are mixed in amyotrophic lateral sclerosis. Okay, you get the exact mix between upper motor signs and lower motor signs.
So the purpose of this slide is to just show how complex things can get. Keep an open mind. So there were some special nerve examinations, which I think Dr. Soki will take us through in the bedside teaching. Other than that, I think we're out of time and wind up. Any questions?
Hard's was the last one.
What? Yeah, where was the lesion?
So radial. Yeah, radial nerve.
Yeah, the human. What brachial nerve is.
It can't be.
Yeah, brachial.
It
can't be brachial because, you know,
because
it's
you
one
would have
nerve.
four nerve deformities because they
Most likely.
join and then they separate to form one radial nerve.
Would be like arms,
But that would be more of a Regis tip than a wrist drop. So he wouldn't even be able to lift at all because his hand would just be backwards facing like a waiter stick.
What about the claw?
Yeah, that's on the nerve.
So you just have a wrist.
So if
So you didn't have a claw, he's unable to extend his third, fourth, fifth digits.
And that's which nerve supplies that? Radial. Finger extensors.
no, but a claw hand is ideally an ulnar nerve.
It's not claw, it's slow hand.
It's
No,
a
it's
wrist.
These are wrist.
It's a wrist.
Finger extensors are supplied by radial.
I wish you could have get a video of the hands.
Yeah.
Then you can show
I'm
them.
going to hit you now.
That's like, anyway, next time you add on.
Perfect.
Thank